We've got so much good morning. But we are going to go ahead and get started. And well, I know we'll have some others who will be joining us, but we want to try to stay on time. We do have lunch scheduled, and we don't want to miss that. We have with us today, and I hope everybody has your thinking caps on, because I think whatever you thought you knew about CPAP and BiPAP is all about to be challenged. And I hope that you will ask questions, and I think we're going to learn a lot about CPAP therapy that will be very fascinating, and I think could potentially change the course of how patients are treated from a therapy standpoint. But we have with us today, we have Dr. William Noah. He is the CEO and founder of Sleep Centers of Middle Tennessee. It's an extremely busy, successful sleep program in that part of the Tennessee market. He's also the CEO of SleepRes. He's the founder of the VCOM. Has anyone heard of the VCOM? All right, we got a couple. All right. I know that there are a few at the React tables, so you should take one home with you. It's a little adapter that will help to, it's training wheels for CPAP for patients who are new to CPAP therapy. So it'll help those patients be able to tolerate the pressure much better. But please give a warm welcome for Dr. Miller.
All right.
You're on.
Thank you.
I think that's the last man share slides.
You get the first one up.
Yeah, there you go. There we go.
All right. So, is that good? Thank you, guys. Today is always tough to give this talk, but I do it quite a bit. Today's a new set of slides, so I may mess up. You may find some typos. I was still finishing it before we started because I've been having this funeral for BiPAP, and so today I decided I'd stick a few more swords in it and we go on. So the take-home points today are: early CPAP devices had lower inspiratory pressures. All right. But, well, we'll get to that. Then, of course, also remember BiPAP was put out by Mark Sanders and Respironics because they thought, well, we could lower EPAP because about 30% of people complained of difficulty exhaling. We could improve adherence and we could decrease adverse effects. But it failed. Okay, BiPAP and its offspring, C-Flex, EPR, and other expiratory pressure reduction algorithms have failed to improve adherence and decrease adverse effects. Reducing EPAP with BiPAP destabilizes the airway. Yes, ma'am. What's up? Okay. It destabilizes the airway, which increases resistance and flow limitation and actually worsens obstructive sleep apnea. Higher IPAP cannot stabilize the airway. It's only providing pressure support to increase flow across the obstruction you cause when you reduce EPAP. If BiPAP and EPR and other algorithms improved adherence, then this reverse approach to therapy would have merit, but they did not. BiPAP should have died in '95. The concept of intentionally lowering inspiratory pressure does not previously exist. In other words, no BiPAP can lower inspiratory pressure below expiratory. So I had no way to test the theory, so I made a resistor to do it, and after proving, we released it to market. And we're going to see that it improves comfort, possibly adherence, provides the same therapy, and reduces the adverse effects of leak, mouth opening, and resolves TEXA. We cause TEXA with C-Flex. So that's what we're going to cover. Y'all ready? You already ready? Get your rocks ready to throw at me, okay? Okay, early CPAP had lower inspiratory pressure because when you breathe in and dump the flow into your lung called tidal volume, the pressure had to drop. Of course, about 30% of people on exhalation had trouble breathing out. And in surveys, Kingman Stroh and Susan Redline, I'm sure you both know, Susan was actually a fellow. Now she's the 43rd ranked scientist in the world, recently came out. She was a fellow under Kingman, and you can see the pressure is dropping from about 14 to about 7 when they're breathing in, but they weren't having respiratory events. So in 1990, my good friend Mark Sanders, who got to know well the last year, invented BiPAP. His thought was I could lower the expiratory pressure and then give higher inspiratory pressure to compensate, and that would increase adherence because 30% of people had trouble exhaling. Well, beginning in 1995, with Priest-Hochet, we found that it did not increase adherence. And there's been about 20 different studies, most of them randomized, that showed it didn't increase adherence. But we continue to order it and continue to use it. And you could have a draconian view that it made billions of dollars, $30 more you could make a BiPAP. But I think we all believed it. I know I did. Until 2 years ago, every patient in our lab, we have about 15,000 referrals a year, everyone got a expiratory pressure release. Everyone had C-flex. We used BiPAP if they weren't tolerating it. So I was as guilty or more than anybody. But when you reduce EPAP, and this goes back to 1992 using rapid CT, you just decrease the cross-sectional area. You're done. And you can see on this, the middle one is CPAP alone, and then BiPAP's the lower one. See the airway smaller. And then the French group showed using somnol fluoroscopy. You can't use it anymore because of all the radiation. But they showed basically reducing EPAP reduces the expiratory cross-sectional area. You're making the airway smaller. You're making a smaller straw to breathe. You're causing more respiratory events, they found, when you reduce EPAP. And this study out of Canada really kills it. You look on the far right up D, BiPAP 11/11, which is CPAP. Just dropping it to 11/10, you can see in the third row, it reduces flow. So reducing EPAP just 1 centimeter decreases flow. It causes flow limitation. If you have an arousal or 3% standard or 4% Medicare, guess what? That's a hypopnea. So we're destabilizing the airway. We're treating them backwards. So the question is, this is what you have to kind of get through today in a couple minutes and be fine. We know that reducing EPAP, but only enough to cause hypopnea is not apneas, because we all know that EPAP cannot treat apneas. All right, when we do that, we can increase IPAP and often treat the hypopneas, right? You all know that. And if you're in the sleep techs, it really helped me the most of this, because they're the ones there in the middle of the night, keep going up on IPAP and the events aren't going away. But how does IPAP treat hypopneas? Because we know that it has activity against hypopneas. Well, everyone knows delta P, the change in pressure or the effort, equals the resistance times the flow squared. So when you decrease EPAP, you decrease cross-sectional area, right? The airway, the straw gets smaller. Now, when you do that, the resistance is going to go up by the 4th power of the change in diameter. So as your diameter drops, say 2 millimeters, it's going to go up to the 4th power of that, okay? So that's times 4, times 16, that's times, what's that, 16 to 256. So that's your resistance going up, okay? So it's a lot. Now, what you can do when the resistance goes up, we'll get the equation. By the way, if the resistance goes up and the flow drops, and you have what, the 3% DSAT or an arousal, that's hypopnea. Or if you make more effort, delta P goes up. You know, you can pull more flow across that resistance, but if that extra effort causes arousal, that's a rare. It's the same thing. It's just increased resistance in the airway. So what is BiPAP doing? Well, BiPAP cannot increase the airway size. IPAP can, excuse me. And you have 3 slides here. Now you all choose which one of these 3 you want me to cover, okay? You want me to cover this one? Do you want me to cover this one? Or you want me to cover this one, all right? So I told our engineers last night, I said, can you send me some simpler slides on viscoelasticity and on cross-sectional area? Sure, sure. And I looked this morning right before I came in here, they were worse. So I don't know why they love these differential equations. I mean, it's been frustrating the last 2 years having to relearn physics and calculus. But basically it's this: when you decrease cross-sectional area, this will make perfect sense to you. There's less surface area. The smaller the pipe, the less surface area, right? And by the way, I want to tell you this balloon thing. My wife and I were at the airport somewhere. We were at the airport, broke loose or something. I think I've had a major malfunction. There we go. I'll set it here. We were at the airport yesterday connecting to Charlotte. We're sitting here stretching these balloons, trying to make. I couldn't inflate them. I was going to give you a real, live one, but I don't have the ability to inflate it. But basically, when you decrease the size of the pipe, the cross-sectional area is less. And pressure is force over what? Area. So when you decrease the area, you decrease the force. So think about a ship. The bigger the sail, the more force that can push it. By the way, the wind doesn't push it. It's the pressure change over the sail. Okay. By the way, flow doesn't exist without pressure change. Flow does whatever pressure tells it. Okay. Just like I do for my wife back here. Okay. So pressure really does do that. So when you decrease the area, you decrease the force at the same pressure. In other words, 10 centimeters of CPAP on an airway like this has less ability to open than it does on an airway like that. That's why when you're titrating upward, it takes more pressure. Say you go from 5, you may have to get to 12 to get rid of their flow limitation. But if you started at 15 and came down, you might treat them at 10. Make sense? And it's because, so when you decrease the cross-sectional area with EPAP, when you drop it, right? It's going to take more pressure to have the same force to open it up. Well, that's the first nail in the coffin. The second nail in the coffin is this, is that the airway is viscous. It's not purely elastic. And all our models, like the Starling resistor, are all elastic, where there's no time delay, like a spring. But it's like memory foam, where you push in, it takes a while to push in, and then when you come back, it takes a while to come back. That's how the muscles in the airway are. They're viscous, and they have a time constant. Here, I'll show you what it is. All right, cover your eyes. So that time constant means that IPAP is too late because there's a time delay. So if you're giving it an inspiration, it isn't going to open the airway. It can't. All right. That's how nasal EPAP devices work. They're flow-dependent pressure in early expiration. Well, how does a nasal EPAP device, you know, the resistor in your nose, was it Provent was the first one. And now the Briggs device, you all need to go try. Jeffrey Sleeper over here in the exhibit hall. This is one with headgear that actually people can wear. But anyway, how do they work? Well, they work because of the time constant. You're giving pressure early in expiration, but it's still treating them in inspiration to treat snoring and hypopneas. See, IPAP's too late. But the final nail in the coffin is this. Let me see if I can get this to work. How do I hover over it? Okay, there we go. Called stupid balloon tricks, which I couldn't do. So you have to watch. Now watch this balloon. See how he squeezes? So what he's done, which I couldn't do for you, is he's taken an area of the balloon, he's stretched it. And therefore he's made that more compliant than the other parts of the balloon. And so what happens is when he squeezes, it's going to go to the more compliant part. The air just hops over there. It's a cute trick for kids, but it's the death of BiPAP. Because what happens when you breathe in is that pressure is going to go to the most compliant part of the respiratory system, which I can't believe I didn't figure this out for 30 years. And that's the lung. And I'm a lung specialist. You think I'd know that. All right. And so what happens is IPAP can't make the airway larger until you inflate the lung completely to where the compliance of the lung gets so stiff that it's equal to the pharyngeal wall compliance, and then it could open the airway. It cannot. It's impossible for it to do it. IPAP is merely giving more pressure support to overcome the resistance we caused when we destabilize the airway by doing something foolish like dropping EPAP. EPAP is the therapy. Now, one of the things EPAP does that people don't think about is lung volume. That end expiratory pressure creates the end expiratory lung volume. So you want to know how heavy people breathe, just blow all the air out of your lungs and try to breathe them. And they breathe down near the residual volume. And Raphael Heinzer here, Heinzer et al. I was just, I'm a sip of water. That's what my problem is. Can you grab that for me, brother? It's right here, right next to my wife. There's one on the table. Here we go. So Raphael Heinzer, I was presenting to him. I was supposed to be in Switzerland with him, but my flight got canceled twice last week in Philly. So I just came home. So I did my talk in Paris virtually, and then I met with him. I just think the work he did was brilliant when he was with David White at Harvard back in these days. He's back home in Switzerland. But what they did, they made this iron lung. Of course, they make it out of fiberglass now, and though your head sticks out. So they can change lung volume, you know, by changing the pressure inside this cavity. And so they found that by changing lung volume, they had patients that needed 12 centimeters. And if they increased lung volume, they only needed 5 centimeters pressure. That's a big difference just by changing lung volume. And if they decreased lung volume, they needed 17. Think about a patient in the lab who you could treat the same patient with 5 centimeters or 17. It's a huge difference. That's how important lung volume is. That's why, oral appliance therapy, upper airway surgery, hypoglossal nerve stimulator, and the pill that's coming out, they're in phase 3 trials. We're actually participating in that. The sleep apnea pill, you all. It's not going to put you out of business, don't worry, because they don't increase lung volume. And so for people, particularly people who are overweight, it's not going to fix it. And that's why they fail. And now they just increased the weight limit for hypoglossal nerve stimulation. That's just going to be worse. So lung volume matters. And only CPAP, EPAP particularly, can increase end expiratory lung volume. So the 4 advantages of EPAP for optimal EPAP, and I say optimal, the reason we use a 22 millimeter tube is if you want to use a 28 millimeter tube, it wouldn't really make any difference. The resistance is so low, the pressure drop over a 22 millimeter tube is not that much. But when you go to 15, now you got a 1.5 centimeter pressure drop. The machine has to counteract for it. Or if you use a 12 millimeter hose, then you've got to what? You've got to drop. The machine has to counteract 2.3 centimeters of pressure. So optimal EPAP is where you get the EPAP such that, well, increasing it more doesn't really improve therapy. So as far as cross-sectional area of the airway, only EPAP's going to change that, not IPAP. EPAP's going to increase end expiratory lung volume, right, and decrease the pressure they need. IPAP cannot increase end expiratory lung volume because it doesn't exist during inspiration. And EPAP provides safety from rebreathing. That the amount of air coming out those holes is dependent on the pressure in the system, and it's the expiratory pressure that's getting rid of CO2. IPAP cannot. And EPAP actually decreases work of breathing. If you blew your air out and tried to breathe down there, it was hard. EPAP increases that end expiratory volume and makes the lung more compliant, allows the patient to generate more tidal volume with their own effort, and it's before you start giving pressure support to a system. In other words, you have someone who's on 15/5 and you're ventilating, and they're not making their tidal volumes, you're going to go to 20/5. That's not a smart move if they're overweight. You probably have to go to 15/8, may give you more tidal volume because you're allowing the patient's lung to be more productive, and the pressure support you're giving will be more productive because you just improve the compliance of their lung and their respiratory system. Yes, I didn't figure this out till a couple of years ago. It took 30 years. I'm a little slow. All right. So the children, the offspring of BiPAP, expiratory pressure reduction algorithm, starting with C-Flex in 2003. The way it goes, Respironics or Philips does it. The others, I won't name names, copy it all the way along. Whether it's good or bad, they copy it. So problem with this is they didn't improve adherence. All right. Randomized trials, they don't improve adherence, and they're associated with compromised therapy. The Spanish group showed. And then Masdud, that's David Rappaport's group, they showed that the pressure changes don't even translate to the pharynx because they put a pharyngeal manometer in there because engineers only engineer the face. And 2 years ago, when I dropped everything and done nothing but work on this, 2.5 years, started interviewing the engineers, and I started talking about pharyngeal pressure. Well, stop. What? They go, we can't talk about that. We're only allowed to talk up to the face in the machine. We can't discuss physiology. I said, but physiology starts with the word physics. We have to get somewhere. And they have no idea. The engineers have no idea about the effect of lung volume when they're making the machines. Okay. And then as physicians, I thought I knew how they work, but I don't. I guarantee you, I can tell you everything about one now. Every little aspect. But I didn't know. I thought it was a ventilator. I would, know everything about the patient in the ICU. I'd know the resistance, the flows, everything, their static compliance, their dynamic compliance. I'll just give them 5 to 20 CPAP and I'll see you in 2 months. All right. That's kind of how it was, embarrassingly. What about mass compensation algorithms? Well, this is the ultimate foolishness in the understanding of IPAP. People are so concerned about maintaining inspiratory pressure that the engineers at Respironics, I know who they are, and I've interviewed both of them, they thought, well, that those masks have different resistances, and that nasal pillow has all that resistance. We've got to jack the inspiratory pressure up higher to prevent the drop in inspiratory pressure across that resistance. So when you take your mask selector and you put it on a nasal pillow mask setting, you just jack that inspiratory pressure up higher, and you turn the nozzle going up in their nose into a pressure washer against their nasal mucosa. And starting in 2010, they basically killed the increased adherence we were getting with nasal pillows in the 2000s. because they started jacking the pressure up. Now, fortunately, most people didn't know this was on the machine. They never set it any different. So a lot of them were probably still on full face setting. And bottom line is they never even tested this on patients. They just put it on the machine. Hard to believe, isn't it? Never tested on patients. It's embarrassing. It really is. And when they came out, I made sure all my respiratory therapists looked at it. Make sure you turn that machine, because we use nasal pillows, put it on nasal pillow setting. Because there's something about that resistance. They told me that I need to have it set there, but I never investigated. Because the belief is you have to maintain IPAP, and that's the priority of therapy. So what did I do? I said I need to figure out a way to drop it. Well, I couldn't drop it because what? No machine can have IPAP less than EPAP. So I made these first 3D printed little toys back in July of 21. And then I decided the best thing to do is just release it on the market. You know, manufacture it, do the FDA thing. So we released it at APSS in June of 22, the VCOM. And what is it? It's just inline resistance, and it's the dotted line. You can see flow is on the bottom on the x-axis, pressure change is on the y-axis. And at low flow, you have no pressure change. But at high flow, you have a lot of pressure change. Now, those other graphs are the cushion of a P10, a Nuance, and a Rio from React Health, and a 12 millimeter hose. So the resistance is actually less than other things that are in the airway, you know, that we use all the time. But it's where I put it. And you put it before the exhaust. So you put it between the mask and the hose, or between the machine and the hose. It can go either place. It doesn't matter with resistance. And so during inspiration, there's high flow. You have the patient flow, the tidal volume, and the exhaust flow both over. So you're going to have pressure drop. And during exhalation, well, you don't have any patient flow, and the exhaust flow is mainly coming from the patient. So the flow is real low, so you don't have pressure drop. So you drop inspiratory, maintain expiratory. So our lower inspiratory pressure is more comfortable for patients. I mean, that's the question you want to know. That's what we're looking for, right? Trying to make it more comfortable, hoping that'll turn out to higher adherence. And the answer is absolutely it is. A large DME in Michigan finished the trial. 46 out of 47 patients preferred the VCOM as far as comfort. Large medical practice in Tennessee, that's us, that's our data, so it's tainted and biased, right? So we had worse outcomes. We only had 51 out of 54 prefer it. At 12 centimeters. What about long-term users? Well, we weren't expecting this. You know, Robert said it's training wheels. That's what we call it initially. We don't anymore. Well, about 70 to 75% of long-term users preferred it in our safety data, and that was really surprising. And what were comments they were making? Why they chose to use it long-term? Well, noise, comfort, aerophagia. I don't know why it was better. I know my wife makes me wear it. When she heard that it helped keep your mouth shut, I had one in the next night, but I had to explain to her it doesn't work during the day. So, yeah. All right. Here is the first bi-level PAP device ever in the world that had IPAP less than EPAP. And I want you to know I'm now the fourth largest CPAP, BiPAP manufacturer in the US. You know that? I'm the fourth largest. I've made 5. And this is the first of our 5 prototypes that we're doing studies on. And Robert Miller has breathed on, or you breathed on one of the other prototypes, but you breathed on one. This is where we're dropping the pressure inspiratory between 0 and 6 centimeters. And obviously at 8. And where it says TPAP in that top, that's supposed to say CPAP. We call it TPAP because it's therapeutic PAP, and that's our name, but it's the CPAP setting. But when you're dropping inspiratory so low, you could say it's the EPAP setting. It was the CPAP they were on before we dropped the IPAP. How's that? Anyway, if they're on 8 centimeters, the average drop they like is about 2 centimeters of inspiratory pressure. And on 12, about 3.5. Now, 16, we only did on those with BMIs greater than 35. We weren't going to, blow up a bunch of skinny people. I can take 16, let me just tell you. So why? Why is it more comfortable? Why is dropping inspiratory pressure more comfortable? Well, Kingman Stroh, about a year and a half ago, when I introduced this to him, I think he hit it. He goes, it makes perfect sense, Bill. It's more natural. Humans are used to breathing with lower inspiratory pressure. All of you right now are breathing with lower inspiratory pressure. The room is 0, you have to go negative in order to get air in your lung. It's what humans and animals do. And then David White, who has really jumped on board, he's having me go all over the world, meet with all these other world leaders, to get them to breathe on this, because he thinks it's the greatest thing ever. And I tried to get him to shorten his quote, so I'm sorry. So you can read it if you want to. But the world is going to change. And this is the first time I actually ever said it this strongly, because, we have enough data now that it's just obvious. So will lower inspiratory pressures affect therapy? That's the second question. And by the way, as far as comfort, it's something you experience, right? So you can experience it today. I had React Health. They've got 90 masks in there. You can try your own mask. You can try with and without the VCOM while you're here at the conference at the React booth. And you can determine for yourself. And we'll talk about the end, your patient should get to choose. But the next question you should have, okay, it's more comfortable, is it going to affect therapy? And the question is, it can, but the VCOM is always going to do this. It won't do anything else. See that equation right there? If you want to know how it's going to change, it's always going to change based on what the flow rate is right there. So, at real high pressures, could it drop a 0.5 centimeter of the expiratory pressure? Yes, it can. You just have to compensate. Of course, you titrate, like labs all over the country are now. You titrate with the VCOM in the circuit in the lab, and it doesn't matter. They're already set up where they need to be. Data from the University of Utah on the left is a pressure tap at the mask on 10 centimeters without a VCOM. And on the right, you can see the VCOM. It dropped about 2.5 centimeters inspiratory pressure. And they did numerous of these and had no increased respiratory events. This is our safety data. So we did 20 React Health devices, 20 ResMed, 20 Philips. I know there's an extra one there. And we found that it did not change the P90, P95. They did 4 nights without VCOM, 4 nights with the VCOM, absolutely no change statistically. But they had decreased leak, considerable decreased leak. They had reduced residual AHI. They had reduced indexes. That was statistically significant. And I can't believe this, but we only use people who are averaging over 6 hours and had no complaints. The average was 7.5 hours. It increased sleep time to almost 8 hours in 4 nights. And we averaged for 4 nights that way. We weren't having 9 to 9. So, and you know how ResMed is. So just because how they are, I did an extra 40 ResMed patients. So I had 60 total ResMed, because really right now they're dominating the market, and they act like it. So, so anyway, we did that, and we found exactly the same thing. It doesn't affect their algorithms, and the treatment is the same and less adverse effects of leak. So then we took these prototypes in the lab, and our prototypes can plug into our sleep, our Neon Code and our Alice, our 15 beds, and we started testing patients. So we were dropping with these machines 2 centimeters, and we were having the same therapy, 4 centimeters, and now we're dropping 6 centimeters. So if they're on 12, they're actually during inspiration, and well, can't explain the rest right now. I will eventually here to y'all, but they're basically feeling 6 centimeters, and they're getting 12 of therapy. So that's the future. That'll be coming. Will lower inspiratory pressures decrease adverse effects? Well, out of 1,700 consecutive titrations, we had 200 that needed chin straps. All right. And putting a VCOM in eliminated 70% of chin straps in the lab, because the lower inspiratory pressure. It's the inspiratory pressure that's forcing the mouth open. It's the inspiratory pressure that's causing the increased leak. That's why it decreased leak in those studies. And you'll love this one. A text came after we started this trial a year and a half ago and said, well, what if someone's aborting? What if they're pulling their wires off and they're leaving? Can we bring a VCOM in for that? Because they're only out of VCOM for mouth opening or for TEXA. And I said, okay, fine, go ahead, do that. Well, this is shocking. We had 47 aborts where they were pulling the wires, going to leave, and they brought a VCOM in, and 43 out of 47 with the VCOM completed their titration. But the one I was most interested in was TEXA, treatment emergent central sleep apnea, because I had this theory. That's why I only could test it, was really to release the VCOM. And you can see at the top, we did 1,700 studies consecutively, not counting BiPAP. And with C-Flex Plus on, we had 2.6% of patients develop TEXA. With it off, 0.3, a 10-fold increase in TEXA. And my theory, I think, is right. We caused it. You see, C-Flex comes out in 2003. TEXA is described in 2005. And that little bit of pressure support, that little bit of IPAP higher EPAP augments tidal volume. And if you have a high loop gain and where your apneic threshold's close to your eupic threshold, your eupic CO2, you're right up here. It needs a little bit of increased tidal volume to blow you below, and then you're going to have a symptom. And then the thing starts. You know how it looks. Once you get one, they come in waves. So we caused it. And we should have figured it out because TEXA is more common with BiPAP, and there was an abstract where it was more common with C-Flex and with lower BMI. Because lower BMI, the pressure is going to affect you more. Someone who's got a little more on them like me, pressure is not going to bother me as much as it is someone like Jeffrey SleepRes, my friend out there, you'll see with the Briggs device. So the thinner you are, the more the pressure is going to augment your volume in your lung. We have hundreds of anecdotal reports of aerophagia being reduced with the VCOM. That makes sense because you're augmenting tidal volume in the lung, you're augmenting airflow into the esophagus. If your lower esophageal sphincter doesn't work, it's going to go on down the other way and surprise everyone in the morning. And we have a formal trial waiting IRB approval. Early adherence data. Well, a large DME in the Midwest now reported 12% more patients meeting Medicare requirement at 3 months with a VCOM in the circuit. And a large DME in the Southeast, they had a protocol with 30 days, they didn't do anything, and if they were struggling, they gave VCOM, and they found that with the VCOM in the struggling patients at 30 days, doubled the usage during the next 30 days. And I just got a bunch of data from them yesterday with really good adherence data, but I haven't had a chance to process it and look at it yet. What about the BiPAP tritation? Well, I mean, it just needs to go away. I sat on that committee for 3 years, about 10 years ago, and I never thought about any of this. I mean, you know, there's no data behind it. It all goes back to Dr. Sanders' study. We don't know. We just sit around with a glass of wine, a steak, at a dinner, the whole committee, and go, okay, that sounds good. We'll do a half a centimeter here, a centimeter here, 2 centimeters there. There's no data. We believed all this without data, and the data shows that we were wrong. We should have killed it at 95. And then we let it have offspring, C-Flex and all the others. So the take-home points. BiPAP, introduced to improve adherence, didn't work. EPAP with BiPAP, lowering EPAP destabilizes the airway. You're just making them worse. And the higher IPAP can't stabilize it. So using an inline resistor, we have improved comfort, provided the same therapy, and reduced adverse effects. The exact thing that Mark wanted to do in 1990, we have done now. It's the inspiratory was the problem, and we just never looked. So what can I do for my patients right now? Well, here's my opinion, and it's heavily biased. Always set mask selection setting on the PAP device. Always set it to full face setting, okay? Because it doesn't jack the pressure. You'll get whatever the CPAP setting is, all right? Number 2, turn off C-Flex, Reslex, EPR. If the patient has trouble exhaling, try a mask with less resistance, okay? A nasal pillow has a lot of resistance. And of the nasal pillows, the Philips masks have more resistance than the ResMed or the React. You can switch like from a Nuance to a Rio. But of course, at higher pressures, that resistance is helpful to the patient. So we use, based on their exhaust flow, the higher exhaust flow we use at low pressures because of rebreathing, and we use lower resistance masks, and at higher pressures we use the other. And then the other thing is just give them the pressure they can tolerate. Say, I can't exhale against 8. Well, Ms. Jones, you need 11. Well, okay, just give me 8 now. In a week or so, let's move it up. That's what we used to do, and that's what we still need to do. Don't compromise their therapy. And then lower their inspiratory pressure to improve comfort. You might be shocked how they can improve the expiratory. And there are multiple ways I can manipulate the system to do that. I can put a 12 millimeter hose and somehow break the little flange off so the machine doesn't know it's 12 millimeter, kind of do the same thing. But look, the easiest, safest, the most tested is right now the VCOM. Now the VCOM I obsoleted, I'll be honest with you, before I released it with the algorithms that will be in machines and stuff. But for right now, it's going to be a year or so. So for right now, you can use that. Just like choosing a mask, patients should get to experience lower inspiratory pressures during setup and choose for themselves. Let them choose, okay? And you should experience it too. You need to know what it feels like. I was shocked at APSS. when we introduced this, we had 300 sleep physicians, put on the mask and feel the VCOM at night. And I was shocked how many of them never worn CPAP. Well, God, this is horrible. How do people handle this? I'm like, you've only written 10,000 prescriptions. So, so the first question I always get is, how can I get VCOM? So I just made a slide yesterday. I apologize, for any commercial here, but it just answered it. Number one, if you're a prescriber, just prescribe it. Write it on the script. Let the patients choose. Or if you have a physician over your sleep lab, go to them and tell them, just put it on the script. Let the patient choose. Insist your preferred DME, offer it for free to patients. I mean, it's dirt cheap to them. And if they buy React Health machines, they get it for free. React Health machine comes with a VCOM on every one if they order that way. To send a patient to get a patient one, they can go to getvcom.com. Now they have to pay retail. Pay for it's like $30. The DMEs can buy them for like 10 to 15 or less, depending on how they get them from React. It's a different deal. And if you want one, for your labs to play with or something, you can go to SleepRes.com as a provider and get one. So that's my story. Questions? Yes, of course it would be you. And you're representing the consumer, the wearer. Right?
I've been using it and myself for probably a year. I don't know, a long time.
Yeah.
And then I just tried it, and it really helped with derivation for me. So I just carried on using it. Still got it in there. I just took it in last week's test a couple of weeks ago and took it with me. And the tech had never seen it before, and I just was like, "Can we keep this in there?" And she was like, "Sure, that's fair." So yeah. But my question was, so you talked about there are different settings for nasal pillows, nasal masks, and full face masks.
Yeah.
So because the pressures are all like we're talking about different pressures depending on the type of mask. So what should patients do with that information? Like if we're using a full face mask, or staying on the full face mask setting? Like
every machine we put out is set on full face setting. Because every type of mask, because they were foolishness. They never checked them on patients. If they had checked them on patients, they would have found that 100% prefer the full face setting with a nasal pillow or a nasal mask because they have more resistance. So they're jacking up the inspiratory pressure. No one wants that up their nose. So they basically made nasal pillows harder to wear. We have made CPAP harder to wear and less effective is what we have basically done. And it's embarrassing.
So
I have to admit.
My next question is kind of predictably, when are you going to said you're working on the prototype for your machine with all your algorithms?
Yeah.
So when is that going to be available?
Good question. Could be second quarter next year.
Okay.
That's the earliest possible. I have put it in a machine, commercial machine, and have to do experiments. I don't know who I'm going to give it to. That's the question. I don't like any of them except, or I do like one, but it's a tough situation. Okay. But I can tell you right now, React Health has got the VCOM and they're pushing, and that's what our goal is. And it's a huge political thing with the, and it may come out in Europe first. Well, that's a possibility. But no, I mean, we're not really wanting to make machines. I want to keep working and get more algorithms. I've got other stuff we figured out. We want to develop ventilators. We've got more. I really don't want to be involved in all that. But unfortunately, I'm stuck in the middle right now. You would have to ask that. I think I'm going to give it to Apri and just let them do it since Bob's running the conference. Robert's running the conference. Any other questions? I see back. Yeah, it doesn't say that on the package, but like masks don't say that either. You do the same, so it's pretty. It says to wash it every day. You have to say that on there. I've never washed one. I've been using it for a year. Anyway, if you don't take it in and out every day, it lasts longer. It's a softer sort of plastic, so it seals better. When we were designing, it was really funny. The first ones had like 20 holes that I made, and then I tried to create the same resistance, drop it a little bit. I made 4 holes, but then I created the Andy Griffith show, just whistled all the time. So the most engineering I did was to get the whistling going. Any other questions? How do y'all feel? Who's a respiratory therapist? I mean, how does this make you feel? I mean,
Makes me feel hopeful because I used to see CPAP at
uh-huh.
times, and I'm out there blown open plenty of times, dry throat and everything. I want to try it.
Good. Well, like I said, it didn't fix everybody. It's not the only answer. This isn't the only answer, guys. But I'm just saying we've been doing it the wrong way for a long time, and the science showed us that. The randomized trials showed it didn't work, and we kept ordering it because we believed it. It's like many things in medicine. You can believe it all you want, but we're just wrong. How about sleep techs? What do y'all think? Well, I can tell you, my techs want to stop all these stupid trials and just use VCOM on everybody like other labs are doing because they can stay in their chair. They don't have to get up and fix text in the mouth opening. Uh-huh.
And it was awful, around freezing and stuff. And of course, I still haven't got the medical director on board yet. I talked to the lady out there. And she said that admission. I'm still working on it.
Well, we can get them for all your labs. That's what they're there for. Friends don't let friends treat people with higher inspiratory pressures. So central sleep apnea, we talked about that. So treatment emergent central sleep apnea when they start. In fact, I just got this email. Where's my phone? My wife's got it. This morning from the head of the Oshner clinic down, their labs in the South Mississippi, New Orleans, about how they didn't now use VCOM on everyone, and they're not having centrals. They had one last night. Who's failed CPAP, BiPAP. They came in, we're having all these centrals, put a VCOM in, and the patient was able to tolerate it. Their centrals went away. They just wrote, to whom it may concern, put it to our website. So I just saw that. We get reports every day of that. So by lowering the inspiratory pressure, you're not augmenting tidal volume, and therefore you're not going to create centrals. Now that's different than with narcotics, a whole different mechanism. It's not going to fix that, but it's going to help with the other. Oh, that's for sure. Shane Stokes, we haven't done any testing on. But as far as run-of-the-mill treatment emergent centrals, when you start therapy, VCOM is resolved 100% of the cases. Actually, I don't think I covered that on the slide when I got there, but you saw on our study, every case that we have put a VCOM in for Texas, out of 1,700 studies, the VCOM resolved the treatment emergent in every instance, 100%. I'm sorry. Did that answer? That help? So I haven't done any testing with it yet. I have theories on it, but I don't want to get in any trouble. Like for instance, everyone's pushing about ventilation right now because it makes ventilation more comfortable. Not that you don't want to drop IPAP because they got to have the pressure support to ventilate, but it rounds off the square wave, which was wrong. It's more comfortable. They can control it. It's like having a patient adjusted rise time. They can change it for each breath because the resistance knocks that down at them. So, but I say only under, physician supervision because I don't want someone sticking a VCOM in, knocking their inspiratory pressure down, dropping their tidal volumes and causing a problem. You can use it. You just need to know what you're doing on that. And so we're just trying to make sure it doesn't interfere with anything. I'm just trying to prove a point. We'll come out with more in the future on this. Well, what do you think, Robert? Is Apri going to order like 10,000 tomorrow?
I think there's too much right there. Go home and burn their physiology books that they some of their old literature that they used in their training. I have to tell you, I have had the privilege of being able to breathe on the different algorithms as he has progressed in his development of the product. I'm absolutely a fan. And most importantly, we want it to be therapeutic, but we want it to be comfortable and something that patients can be adherent to. So stay tuned. There's the future is about to change.
Thank you, guys.
All right, we got the list up in just a second, but real quick, let me give a couple of the lowest RPSPT registry number in the room. Who thinks they have the lowest? 268. That's pretty low. All right, she is a winner. How about the lowest respiratory therapist or the longest tenured respiratory therapist in the room? 28 years. 30 respiratory. In respiratory? Oh my gosh. She's 38 in respiratory. And the lowest registered RPS number. All right, so who's the next person on the respiratory side? 30 years. We got two people at 30 years. All right. 30. 30. Oh my gosh, I got three. Anybody go for this? All right, let's do that. Here's the winner. All right, lunch is going to start in the room next door. So we've got an hour for lunch. Grab something to eat. We'll come back and here's about some sleep apnea stories.